We will first start by doing the examination for global assessment. Before the start of every physical examination, the following details should be initiated. The mnemonic YP can be used as a reminder. W stands for washing of hands, I for introducing yourself, the second I for identifying the patient, the first P will be for permission to examine, the first E will be to explain the task ahead, the second E will be to expose the area to be examined, and the last or second P will be to position the patient appropriately. We will also do vital signs. So for this examination, we will first have the patient stay outside the room, and when you're ready for the examination, you will ask the patient to walk into the examination room. As the patient walks in, you will listen for foot slapping during walking. You will listen for any examples of noisy breathing or stridor. You will observe the stance and swing of the patient's walk and make note of the following. General state of health, make sure the patient is healthy, make sure he doesn't look acutely ill or chronically ill in health. You'll check out his height, his weight, and build, and you will get the appropriate weight for height for your patient. You'll be checking out his posture and his gait, so for that you will ask the patient to walk back and forth. And we will note any involuntary movements of the head and neck, trunk, and or extremities. The grooming, the eye contact, and the personal hygiene and odors are also to be examined, and we will check out the patient's facial expression and facies. We will also talk to the patient and make note of his manner of speech and state of awareness.
Hello, how are you, Dr. Celestine?
It's good to meet you. I'm fine, thanks, and yourself?
Yeah, good to meet you. So what's your name?
Christopher.
Oh, good. Nice to meet you.
And then with the patient sitting on an examination table, we will do a survey of the patient from head to foot to make note of any abnormalities in the head and neck and the other regions. We shall then proceed with a skill of palpation, and with the patient sitting on the examination table and appropriately attired and positioned, we will palpate things like the head and neck areas, followed by the extremities, and we'll be checking for things such as tenderness, swellings and masses. We will also be performing the passive range of motion of the joints. We'll be checking for things such as abnormal pulsations, tracheal deviation. We'll be palpating for muscle tone and strength, which we will grade from 0 to 5 when we do that. We shall also be testing for reflexes. When we test for reflexes, we usually utilize the instrument that is called a reflex hammer, as demonstrated here, and we will do that further when we get to CNS, but usually we will use it for deep tendon reflexes. So usually you palpate the tendon. It's usually a soft spot between patella and the tibial tuberosity. Then, with the hammer, you make a flick of the wrist and try to distract the patient. There we go. And you can try the same thing at the other extremity. There we go. And that's an example of. We will also be checking for certain things as when the patient is standing, such as palpating the spine, for things such as scoliosis or anterior curvature, as well as muscle spasms of the neck and the back. Then we will ask the patient to lie, in which case we will do the appropriate draping. And we will stay on the right side of the patient. And as it's appropriate, we will expose their chest and abdomen as is necessary for the examination. And we shall be palpating for things such as tenderness, thrills, heaves, pulsations, and dilated veins and arterioles. So, in order to do palpation, we will first demonstrate the appropriate means of doing it. You should use one hand initially, and you should place it across the patient's examination area, and we will palpate lightly, making sure that the ulnar border of our hands as well as the rest of our fingers are in contact with the abdomen. As I said before, palpation is looking for things such as tenderness, swellings, masses, and dilated veins. Within the skill of percussion. So we examine the chest and the abdomen simultaneously with the shirt off and the abdomen exposed all the way down to the iliac crest. The technique of percussion is as follows. In right-handed persons, we place the distal phalanx of the left middle finger on the chest, the appropriate intercostal space or abdomen. This is called the pleximeter finger. We then lift the other fingers off the chest or abdomen. We tap with the tip of the middle finger of the right hand, which is called a plexor finger. To avoid injury, the fingernails must be short. The distal interphalangeal joint of the right middle finger is held at about 135 degrees. And the tapping movement originates from the wrist, starting from the dorsiflex position and ending in the neutral position. Strike briskly and the distal interphalangeal joint of the left middle finger with the tip of the right middle finger, immediately lifting the tapping finger and repeating the process. Tap 2 or 3 times. These 2 or 3 taps should be of equal force, duration, and intervals. And then we reverse the hands for the left-handed persons. Please note the sounds emitted on tapping, whether they are resonant, which is usually the case in chest, or tympanic, which is usually the case in abdomen, or hyperresonant or dull, which would be in pathological cases. The final skill is the skill of auscultation. And with the chest exposed, we will be listening to areas such as the lungs for breath sounds and adventitious sounds. Remember, during these procedures, we usually ask the patient to take a deep breath through the mouth, as will be demonstrated here. We can also use a skill of auscultation to auscultate the area of the abdomen for vowel sounds. Or to listen to the apex beat of the heart for heart sounds 1 and 2. All of these skills shall be repeated when the appropriate segment is done in the small group sessions. We usually check out in general from head to toe, the size and shape of the head, presence of symmetry, as we mentioned before, the color of skin, the hair, the presence of congenital deformities, swellings and scars, facies and facial expression, distended neck veins, abnormal positions, involuntary movements, flapping tremors, tracheal deviation. In extremities, we check for skin, color, scars, swellings, edema, symmetry of appearance, muscle bulk, involuntary movements, range of movement of the joints, contractures, deformities, and misalignments. We also examine the palms and fingers for nodules, the fingers for clubbing, the nails for lines, ridges, thickening, splitting, splinter, hemorrhage, separation of nail plate from the nail bed, bruises, ecchymosis, and petechiae. The trunk for movement of the chest walls, involuntary movements, scars, swellings, venous distension, and dilated arterioles. We then also test active range of movement in the cervical and lumbar spine with the patient static. This concludes the global assessment. We will then demonstrate some normal and abnormal gaits. The following is a demonstration of some of the pathological gaits. First, we will have the festinating gait that is characteristic of Parkinson's disease. It's a gait in which the patient involuntarily moves with short, accelerated steps. The second gait is called the ataxic gait, and it is typical of cerebellar impairment. It's an unsteady, uncoordinated walk, employing a wide base with the feet thrown out. It is usually characteristic of a drunken stagger or seen in tabes dorsalis. The third is called the quadriceps gait. It's a gait in which at each step on the affected leg, the knee hyperextends and then the trunk lurches forward. You tend to see this when there is injury of the quadricep muscle. The fourth is the antalgic gait. It's a limp adopted so as to avoid pain on weight-bearing structures. It's characterized by a very short stance phase. The next or fifth pathological gait is called the helicopod gait. It's a gait in which the feet describe half circles, as in some conversion disorders. A spastic gait is a gait in which the legs are held together and move in a stiff manner, the toes seeming to drag and catch. It is usually typical in spastic paraplegic patients. The steppish gait is the gait in the foot drop in which the advancing leg is lifted high so that the toes can clear the ground. It's typically seen in patients with peroneal nerve palsy.